Hello, everyone. Welcome to the last and final day of 2025's Kidney Action Week. I want to thank you for joining for this live question and answer workshop. We are thrilled to have you here and can't wait to dive into today's topic on chronic kidney disease. My name is Mike Spigler, and I'm the Vice President of Patient Support and Education at the American Kidney Fund, and I'll be serving as your moderator for today's workshop. So whether you are tuning in for expert insights or have some burning questions of your own about chronic kidney disease, you've come to the right place. I want to give one disclaimer, though, that this information shared in this live Q&A is for educational purposes only. It is not intended as medical advice. Please consult your healthcare provider for guidance on your personal health. If you have specific health concerns, please reach out to your doctor, and in the case of an emergency, seek immediate attention. Before we get started, please type your questions and comments in the chat box to the right. We will answer as many of them as we can as we go through this next 45 minutes or so. But I want to introduce our expert who will be answering your questions today. I want to introduce Dr. Pranav Garamella. He is the inaugural Chief Medical Officer at the American Kidney Fund, a position he's held just since January 2025, and a board-certified nephrologist and expert in rare kidney diseases. Dr. Garamella provides clinical leadership to support the 1 in 7 Americans affected by kidney disease. He also serves as the Director of Acute Dialysis Services in the Polycystic Kidney Disease Center of Excellence at UC San Diego Health. His research, funded by the NIH and others, focuses on kidney function biomarkers, cardiovascular health, and mortality. He has authored over 110 peer-reviewed articles and serves on the editorial board of Kidney Medicine. He is a fellow of the American Society of Nephrology and has received multiple awards for his work. He earned his MBBS from Jawaharlal Institute for Postgraduate Medical Education and Research in India and an MPH from the University of Minnesota. He completed a nephrology fellowship at Tufts Medical Center and an internal medical residency at John H. Stroger Jr. Hospital. Again, as a quick reminder to everyone joining, please type your questions and comments into the chat box to the right. And while those questions start to roll in, Pranav, let's just get us started with a softball question. What is chronic kidney disease?
Thank you so much for having me, Mike. This is exciting. Chronic kidney disease, as the name sounds, is a disorder of the kidneys that has been around for a long time. And I'll get into the specifics, but essentially CKD is progressive damage. So chronic kidney disease, or CKD, is progressive damage and loss of function. And the way we measure function is by using something called glomerular filtration rate, or GFR. And we can calculate that GFR from a number of different markers. But typically what we do is we measure blood levels of creatinine and calculate that GFR. And if that GFR is below a certain threshold, namely 60 or 60 ml per minute, which is how we measure it, and if it's lower than 60 ml per minute for at least 3 months, we typically think that someone has chronic kidney disease. Now, keep in mind that there are different stages of chronic kidney disease, and sometimes the term chronic kidney disease stage 2 may be used when the GFR is over 60 ml per minute even. And that has to do with whether or not they have protein in their urine, or whether or not they have other anatomical issues in the kidneys that are detected on imaging. So to sum it up, chronic kidney disease is progressive damage, usually measured by GFR, that has lasted at least 3 months in someone.
And what causes kidney disease? What are some of the common causes that you see?
Well, chronic kidney disease is usually the end pathway. It's the end result that we see. And the causes are extremely varied. But if I had to pick the most common one, I would probably say that diabetes, be it type 1 or type 2, is the most common cause of kidney disease. This is worldwide, and especially so in the United States, and it's also the #1 cause of kidney failure. Following that, most people believe that high blood pressure is causative, and depending on the literature you look at, these two conditions can account for almost 2/3 of all cases of chronic kidney disease. Following diabetes and perhaps hypertension, we have a set of disorders that are typically immune-mediated, what we call glomerular nephritis. And this is usually due to inflammation in the filtering units, the small segments inside the kidney that actually filter the blood of all the toxins. And then we have inherited disorders, which are passed down generationally. And the classic one being polycystic kidney disease, which is the 4th leading cause of kidney failure in the country. Rarely, we also see recurrent infections and sometimes obstruction, so blockage of the urinary tract, leading to chronic kidney disease if it happens over long periods of time.
Got it.
Sometimes, and I have to mention lifestyle factors such as smoking and liver disease from alcohol use disorder, and even obesity can be associated with the risk of developing kidney disease.
Okay, great. We have a question that came into the chat regarding hemodialysis. Before I get there, though, let's explain to what that is in case we have some people just kind of in the earlier stages of kidney disease. So when you get to the point where you're in the final stage of kidney disease, what are people's options?
Right. So I'd mentioned stages of kidney disease. So I think this is a perfect time to talk about it. We typically think about stage 3 or significant enough kidney disease when the GFR falls below 60. If it falls below 30, we consider it severe kidney disease. And if it falls below 15, that's when we start talking about it being in the range of kidney failure. And typically, that is when we need to think about augmenting the function of the kidneys to help do the job. For instance, get rid of the toxins, get rid of excess fluid, get rid of sodium, get rid of potassium, things that our bodies typically do 24/7. And when that GFR falls that low and the body can't take care of these things, that is when we need to use other modalities such as either a transplant to do the function of the native kidneys or support the kidneys with dialysis, which is a modality that does the job of the kidneys. Now, bear in mind, dialysis doesn't help those kidneys recover, but it's essentially doing the job of those kidneys until we can find a more permanent solution, which in all cases should be a kidney transplant. And dialysis is can be done in really two different ways. One is by cleaning the blood, which is the most common form of dialysis that we talk about, or hemodialysis. And this is what most people think about when we say dialysis, because they've either seen people or know people who've gone to a dialysis unit multiple times a week, 3 to 4 hour sessions, and either use a fistula, which is their native blood vessel, or a catheter to take the blood out of the body, run it through a machine for 3 to 4 hours, and send it back to them continuously. There's also another type of dialysis called peritoneal dialysis, wherein dialysis is done using a small catheter or a tube put into the belly, and essentially the body's peritoneum, the lining of the abdominal cavity, acts as a filter. And that's fascinating because we can fill that abdominal cavity with fluid, and that fluid then pulls the toxins from the blood, and then we just drain it out, and then we can fill it again and drain it out. So those are the two dialysis modalities, but ideally they should be used as a bridge to kidney transplantation, which is really the only permanent solution for kidney failure.
Great. Okay. Well, I mentioned there was a question regarding hemodialysis, and the question is, what advances are being made or studied to improve hemodialysis care?
Oh, that's a great question. And it's really pertinent because dialysis for almost 50, 60 years has essentially remained the same, and that is using a fistula or a catheter. In recent times, what we are trying to do is first is promote the use of dialysis at home. And I think that is something that everyone should talk to their doctors about if dialysis is being offered to them, because patients who are able to do dialysis at home through more advanced machines that don't require as much water, don't have as many complex settings, actually can do a fairly good job of providing dialysis at home, and in a setting that you can control. And so if, for instance, you have more dehydration or you have low blood pressure, you can regulate how much fluid comes off and do an extra session. The other things that are being done is waterless dialysis machines are being developed. The American Society of Nephrology actually has awards given for innovation, and this product that is currently being trialed is one of those. It can fit into a backpack, and so obviously it decreases the space required. You could travel with it and use it. There's a lot of innovation happening in the peritoneal dialysis space as well, where we're trying to make these machines smaller and more effective, and so providing a lot more freedom to patients to choose the modality. And we're also working on developing wearable kidney devices, so small sensors that can actually do the functions of the kidney. And this is not yet in human trials to the extent that we would like it to, but there is progress being made. And I think we will see dialysis change. There is a huge push for changing dialysis, and rightly so, given that historically innovation had kind of stalled in this field.
Awesome. Well, you mentioned home dialysis, and we do a dialysis at home summit every year. If you want to see past sessions, you can go to the kidneyfund.org webpage there, or you can also look on our YouTube page. That'll be happening again this year in the fall, probably sometime in the November range. So look out for that. It's very similar to this. It's just one day and all about home dialysis. Another question, Pranav, and please, everyone, continue sending your questions. We should be able to answer just about every one, I hope, as we go through here. If a person does have ESRD, do they always have to go on dialysis or need a transplant, or can it be maintained?
Oh, that is so important to ask, because there is no number that dictates when somebody absolutely needs to start dialysis. And I think that's important to understand. Management of patients always is personalized, but when we get down to kidney function in that range, symptoms can present across the spectrum, and some of them are high blood pressure, some of them are due to legs swelling, and sometimes we see electrolyte abnormalities, and all those in conjunction with what the patient is feeling really dictates the need for dialysis. To give you an example, I sometimes have patients who'd have some of these symptoms developing by the time their GFR gets to 14 or even 15. And by the time they reach 12 or 13, we know they need to start some form of kidney supportive therapy, whether that's the home dialysis or in-center dialysis. On the other hand, I have patients who have had a GFR of between 7 and 10 for 1 to 3 years sometimes. Rare, but it happens, because they have no other symptoms. And this could be because of the cause of their disease. This could be because of whether or not they have diabetes, whether they have heart disease, vascular disease, and how their body is able to regulate the ability to function at such low levels of GFR. So the short answer is there is absolutely no single GFR value below which somebody absolutely needs to start. However, when we talk about transplant, we should start the workup for transplant further upstream, meaning we don't want to wait until someone reaches dialysis to actually start the workup, because patients can get transplanted before they reach dialysis. So dialysis doesn't even, that bridge that I spoke about doesn't even have to exist. We can transplant patients anytime before dialysis, and usually they get listed once that GFR hits 20. So I said kidney failure is 15, but from 15 to 20, they could be on the transplant list, accumulating time. And by the time they get to 15 or 14, just get a transplant instead. So 20 is kind of the number used across the nation for listing. Kidney failure is defined typically less than 15, but when someone should start dialysis is not usually dictated by a single number alone.
We are getting really good questions now. They're coming in fast and furiously. So this person said, I mentioned my EGFR dropping to my primary care physician. They did not seem concerned. How else can I advocate for myself?
First of all, thank you for bringing that up and advocating for yourself. The question of what the drop in EGFR perhaps is a little nuanced. And if the EGFR has dropped between 85 and 70, that's a 10 ml drop in GFR. But if that's happened over a few decades, or a few years at least, depending on what the person's age is, what their other comorbidities are, whether diabetes has been well controlled, and whether they're on optimal goal-directed medical therapies, as we call it, we may or may not do anything different, because there perhaps is nothing else to do. I'm not saying you should not be concerned, but there might not be anything to do at that point of time. If the GFR drops from 30 to 20, that same 10 ml of GFR is very important, because now we're talking about transplant listing. We're talking about referral for a surgeon to decide whether or not you'd have a fistula placed or a peritoneal catheter placed. I think depending on what other circumstances there are for this particular person who's asked the question, I would say if you have high blood pressure, if you have diabetes, if you have a family history of kidney disease, if there's any protein in the urine, I think all those are supportive that the drop in GFR is perhaps true, may have consequences, and needs to be looked at again. I'd also say that sometimes sudden drops in GFR can reverse. Those could be acute drug mediated, those could be due to an illness, those could be due to surgery. And sometimes once those acute insults go away, the GFR can come back. And that's different. Initially, I said chronic kidney disease is progressive, but in the acute setting, you can see some fluctuations in GFR. So again, that's why I think it's contextual. But if GFR has been progressively going down, and this is not the first instance, at that point, I think getting asking to be referred to a nephrologist, perhaps, to do a deep dive into getting those answers would probably be the best way to advocate for it.
Sounds great. It used to be we talk about blood tests for kidney disease and urine tests for kidney disease, and that was about all there were. But as we've started to find treatments for new rare kidney diseases, there's new diagnostics, there's even different blood tests, and I think we're seeing some of that in this question. So there's I think it's okay to kind of give this context. My dad's nephrologist directed him to get a kidney biopsy, but my dad wants to get a cystatin C blood test before doing an invasive test. What exactly are these tests?
Well, excellent. So this is a really good question. So I spoke about blood tests and how the GFR is calculated, usually using serum creatinine. So creatinine is a product of muscle, and so we use that to plug it into an equation and get something called GFR. Now, creatinine values giving us a GFR are not the most reliable, especially in people who either have very low muscle mass, people who are older, are frail, have comorbidities, or in someone who's like a bodybuilder and has a lot of muscle mass, because their creatinines are high, but that doesn't mean their kidney function is low. So we use something called a cystatin C, which is a product produced by almost all cells, not just muscle cells, and it's not dependent on muscle. And we know from a fact that compared to measuring GFR, giving a radio tracer and measuring its excretion, cystatin C GFRs are more tightly linked to that measured GFR than creatinine. So now what we do typically is we recommend most people, especially if there is a question of the accuracy of kidney function using creatinine GFR, we get a cystatin GFR. So the cystatin GFR and creatinine GFR can be used in combination to give us the most accurate value. So if there's ever a question whether a drop in GFR is true or whether somebody's GFR is being over or underestimated, we can actually use cystatin C. Now, there's also old school 24-hour urine collections where we give someone a huge jug and ask them to collect all the urine that they make in 24 hours. And that gives you a good estimate of kidney function by using something called creatinine clearance, or all of the creatinine that's being cleared in that period. And all of these are tools. I'm not saying that we should just use one, but the more data points we have, the closer we get to the true GFR. So these are the three tests, along with albumin testing for the urine, which is a marker of injury. And I think anyone who has kidney disease or diabetes should be tested for albuminuria. But these are the common blood and urine tests that are used. The kidney biopsy is perhaps what's considered gold standard for diagnosis. So in essence, we need a small piece of that kidney to look at under a microscope. And we usually recommend that when we have a concern that the blood and urine tests are perhaps either not picking up what the diagnosis is, or if they have certain conditions such as a glomerular nephritis or an inflammation in the kidneys, and the treatment would vary depending on what we find in the biopsy. And so we usually give local anesthesia, put a needle with an ultrasound, monitoring it, and take two small pieces to get to that gold standard answer.
Great. I'm going to go out of order a little bit in the question just because you were just talking about GFR. And the question is, does dehydration have an effect on eGFR? Dehydration.
Right. So typically when we talk about dehydration, we think that someone doesn't have enough fluid on them. And yes, the simple answer is yes. If you are dehydrated, the kidneys are trying to hold on to fluid. And so we are reabsorbing a lot of things. So typically urea and nitrogen that we also excrete is reabsorbed. And so that goes up, and that can be used as a marker of kidney function as well. But if we talk about GFR alone, when the kidneys are perceiving that they don't have enough of blood flow, they stop filtering. And so the blood creatinine levels go up a little bit. And the moment the creatinine levels go up a little bit, automatically the GFR drops. And usually if this is purely due to lack of fluid or volume, giving someone volume back, whether it's orally or through IVs, usually makes that GFR go back down to normal. Again, this is a perfect example of one of those acute settings where the GFR drops and can go back to being normal.
Great. Okay. I'm going to back up to the question. You all are sending in fantastic questions, by the way. I just told my team that, so keep it up. You talked about home hemodialysis earlier, and we're not seeing as many people get it and use it as possible. What are some of the barriers that are causing that to happen, do you think?
Well, historically, there wasn't a push towards developing a home dialysis model. Payers and policies, there was some barriers, but this has changed over the last 6 years. And in fact, there is a large push to have people now dialyze at home, empower them to make those choices. So most dialysis providers, most healthcare organizations, and nephrologists have all partnered together to actually bring dialysis to patients' homes. With regard to challenges, education perhaps was a big one. And I don't mean just patient education. I think the provider's comfort with doing home dialysis perhaps was not as much as it should have been. You spoke about the American Kidney Fund's home dialysis session week. We actually have training weeks like that for nephrologists outside of their regular training. There are home dialysis universities, online courses, online journal clubs to make sure that providers give home dialysis as an option. So for instance, when I talk to patients, my first options for them really are, do you want to do hemodialysis at home? Do you want to do peritoneal dialysis at home? Then gets to the question, why can't you do those two, right? So do you not live in a place that has running water, that is plumbed to do hemodialysis, for instance? Do you live in a single room with pets, which is a risk factor for infections if you're going to be exposing catheters? Do you have access to running water in a restroom that can serve as a drain from the dialysis? So all of these are factors that go into deciding whether someone can do home dialysis. You have to have a stable home. And we know that a lot of our patients are older. Kidney failure is a disease primarily of the elderly. And so if they're frail, if they have vision issues, if they have mobility issues, if they can't lift the bags to do home dialysis, all of these are barriers. The other thing that we're now doing to promote this is actually provide staff-assisted home dialysis, which is great because you think about the nurses and techs in dialysis units.
Right.
People could actually have someone come home and do dialysis. But if you have someone in your family who wants to be trained, that is possible as well. We could train someone in your family to provide that service. So I think, advocating for yourself, advocating for your loved ones to try and bring dialysis home is the absolute right thing to do.
Great. Someone said, how do infections affect the kidneys? It's flu season. I'm concerned that it may progress my kidney disease if I catch it.
Right. And that's absolutely correct. And this is especially true for people who have underlying chronic kidney disease. So the flu is known to affect people who have underlying comorbidities. So whether it's heart disease, kidney disease, cancers, or other immune suppressed states, they tend to have flu that requires them to be hospitalized. And the moment somebody gets hospitalized, we're talking about people having low blood pressure, we're talking about blood draws, we're talking about getting medications, all of which can affect kidney function. So even if the flu directly doesn't damage the kidneys, there's a lot that happens, especially once the blood pressure drops due to a more systemic illness or a sepsis as we think about it. If the flu ends up causing a pneumonia and someone ends up in the ICU and they have kidney disease, almost always there is some degree of worsening of kidney function as they get intubated and on a ventilator. So all of these factors can cause it. But in addition to this, if someone actually gets a secondary infection, so sometimes some people get a pneumonia from a bacteria on top of a flu, and that bacteria spreads to the blood, especially for people who have a tube or catheter for dialysis, that can exacerbate conditions. But even if you don't have that catheter and there's infection in your blood, that can actually cause direct harm to the kidneys. So really trying to not get the flu is a great way of protecting yourself if you have chronic kidney disease. Obviously, we know that vaccination prevents severity of kidney disease, severity of the flu when people get it. and that's the infection, I guess the question is referring to, not urinary tract infections, which when they happen recurrently can also spread from the bladder all the way through the ureters up into the kidney and cause an infection directly in the kidney, causing loss of kidney function.
Wow. Well, I'm going to put this one on a T for you, being a PKD expert. But the question is, are there any advancements being made in the PKD space, either drug or non-drug related?
Yes. Thank you for this question. So I do think a lot about polycystic kidney disease and ways to modify the course of disease. For those of you who are not familiar with PKD, there is right now no cure for PKD. And about 50 to 60% of all patients end up with kidney failure by the time they're 50 or 60. And we have one FDA-approved drug called tolvaptan that can slow progression of kidney disease by acting on a certain hormone called vasopressin. But what's happening now is we're actually targeting different pathways that cause kidney disease that in PKD. So whether this is looking at cyclic AMP, whether this is looking at some immune suppressive pathways like the mTOR pathway, that we in fact are now using genetic tests, and we didn't really talk about this, but we can identify the specific gene causing the person's PKD. And companies are using this knowledge to target how to make sure that that abnormal gene does not produce those proteins, and the normal proteins are produced to a higher level. So this is really targeted therapy. And that's why I think it's important to test for people who have PKD, get their genetic testing done, understand their profile. This is really akin to what the cancer field did 25 or 30 years ago, where they got a lot of genetic information. So while PKD is a great example for providing specific treatments related to gene therapies, we have other drugs that are targeting microRNA inhibitors that are targeting other pathways. A lot of these are in human trials right now. And in fact, has probably been really exciting for PKD with regards to therapeutics coming out. There's also studies showing that managing pain and cyst size by injecting them can sometimes actually not just improve quality of life and decrease pain, but perhaps slow progression. So that is as an alternative as well. And even if patients have really large kidneys, home dialysis from peritoneal dialysis is still an option. So if someone says that, oh, your kidneys are large from PKD, you need to do hemodialysis, that's not entirely true. So again, home dialysis, whatever the cause of the kidney failure is always a good option.
Great. I think your answer to the biopsy question sparked another biopsy question, but when should a person seek a biopsy?
So there are two reasons to get a kidney biopsy done. One is for diagnostic purposes. So if the blood tests show that your kidney function is low, but the rest of the testing does not give a clue. For instance, the serological testing for immune-mediated conditions doesn't give you a clue. There's nothing in the urine. There's no blood. The imaging does not show cysts to suggest PKD, for instance. And your treating physician wants to get a tissue sample to actually diagnose your condition. Because without diagnosis, there are supportive therapies that are somewhat general to most of the CKD patients we see, but we would not be really changing the course of disease. And that's what we want to do. We want to identify the disease so that we can change the course and plan treatment accordingly. So diagnosis would be a great reason. And this can be anywhere in the spectrum of kidney disease. For instance, we would biopsy a young patient without diabetes just if they had protein in their urine to see what they have. On the other hand, if someone has poorly controlled diabetes and has vascular disease, diabetes in the eye, they have nerve damage from diabetes, and they have protein in their urine, it's very likely that those patients may not get a biopsy because we know that they have diffuse vascular disease. That's probably what's affecting them. So outside of diagnosis, we also have prognostic information. So we look to see how much scarring there is, how much of chronicity there is, and whether there's anything that can be salvaged using either high-dose immunosuppressive therapy or steroids, some of which also have side effects. So you want to balance that risk-benefit ratio, and that's when we would do it for prognostic purposes to say, does the treatment that we plan, will that actually offset any risks from giving it to these patients? So if we see a lot of chronicity, a lot of fibrosis, less likelihood of kidney recovery, maybe putting them through all those immune suppressive treatments, putting them at risk for infections is not worth doing. And so those are the two reasons we do a biopsy. And again, across both of them, we could biopsy patients across the spectrum of kidney function, depending on whether we want a diagnosis or prognosis.
Okay. Another biopsy question. Someone is asking, can EGFR drop by 15 points or so following a biopsy? Is that something that can or should happen?
No. Short answer, no. Because we're not doing a nephrectomy. We're not taking part of your kidney itself out. Like people who have kidney cancer, for instance, sometimes they take the cancer out, you have to take out normal tissue, the GFR can drop. With a kidney biopsy, we're just putting a needle in and taking essentially a few cells. So it shouldn't. Of course, each individual case is different, and whether there were fluctuations in creatinine that were perhaps leading to that, we don't know. Sometimes if there is bleeding and there's bleeding into that kidney, that can cause swelling within that kidney, and that can cause drop in GFR. But again, hopefully that should recover, and that should be picked up on an ultrasound or CT scan, whatever else somebody is doing to diagnose that. But short answer, should a biopsy cause drop in GFR? No.
Okay. You mentioned staff-assisted home dialysis service. Is that available nationwide?
It should be. The barrier again is, do the dialysis organizations that are providing dialysis have the staff on hand necessary? And two, will the insurance that the patient has pay for it? And those are really the two barriers. Sometimes we have patients who are either willing to pay out of pocket or perhaps find an insurance provider that will cover it. But the dialysis organizations that are providing the service in that region may not have adequate staff. Now, dialysis nurses and dialysis techs are highly specialized, and they are in short supply, especially post-COVID. It's been really hard to train and recruit people and keep them. That being said, I think nationally, we really need more advocacy on providing staff-assisted home dialysis, because there are a swath of patients out there who can't do it themselves, who want to, but cannot do it themselves. And I think ensuring that most insurances also cover it would be important, because right now, not all insurance providers will pay for staff-assisted home dialysis.
Okay, great. Got several more questions to get through and about 10 more minutes to do. Clearly, this is a session we need to do again next year as well.
Yes.
Who should be a part of my care team? Is a question.
Excellent question. Excellent. Thank you for asking this. Kidney disease is complex. The requirements for it are complex, and the management for it is complex. Obviously, your primary care provider who has referred you to a nephrologist, the nephrologists themselves. We have dietitians who are a critical part of kidney disease management, because so much of CKD management comes down to what the patient does, whether it's lifestyle wise, whether it's their ability to take medications. So having that dietitian counsel them on healthy choices and managing some of these complications such as high potassiums and high phosphorus is important. We have social workers. We need patients to get on transplant lists. We need patients to be evaluated for dialysis. There are a lot of appointments that need to be made. And so whether it's a social worker, a case manager, or in our setting, for instance, in our PKD center, we have care navigators who are able to help the patient navigate the complex web of health services that are required for them to go from CKD to either dialysis to then needing a transplant and long-term management. Of course, then we have cardiologists, we have endocrinologists who may be managing heart disease and diabetes, and we're always in communication with these colleagues in order to make sure that the medications that they prescribe or any changes that we make don't affect each other's plans. So depending on what your cause of kidney disease is, at the very least, I think a nephrologist, a primary care physician, a dietitian, and maybe a case manager, but that team could expand more depending on your needs.
Okay, great. Do autoimmune diseases such as psoriasis affect the kidneys?
Oh, very good question. I briefly mentioned immune conditions, and typically when we talk about those, we think about conditions like lupus and maybe other immune-mediated disorders that directly affect the kidney. Psoriasis is more of a systemic inflammation that affects joints typically, and perhaps bones when it's systemic. Most often we think about it though as a topical skin-related condition, and that's what the effect is on most people. If it is uncontrolled, if there is chronic inflammation that is uncontrolled, that can actually cause a certain kind of protein to deposit in the kidneys, and that's called secondary amyloidosis. And once in a while, we do see secondary amyloidosis from immune-mediated conditions such as psoriatic arthritis. But if someone has skin-limited psoriasis that's well controlled, typically we don't expect that to affect kidney disease or kidney function.
Okay. Is it better to seek out a disease-specific nephrologist, like someone that specializes in FSGS, PKD, if you have one of those conditions?
Yeah, well, that depends on what care you've been getting with whom you have been. So given how rapidly therapeutics are coming to the market for certain disease conditions, such as glomerular diseases, it would be nice to have someone who has the expertise, who is keeping abreast with all the updates in the field to ensure that you are being given all the options for treatment. Now, if you go to a place that has a glomerular disease expert, that's probably your best bet. A lot of people, for instance, are not comfortable treating the complications of polycystic kidney disease, or maybe even educating patients on it. So I'll give you an example. A lot of my patients who come to me having seen a nephrologist for PKD have been taken care of fairly well, but what they realize is they didn't know as much about their disease and perhaps what other options they had until they see a PKD, a specialist in a center. So yes, there is benefit, especially if you have a condition that's classified as a rare disease. Seeking out someone who has expertise in it, at least for one visit, so that you understand what your treatment options are, whether there are clinical trials you can participate in, whether there is off-label use of drugs that can help, perhaps, would be important, because most nephrologists otherwise perhaps may not be thinking about this, given how many patients they're caring for. Not that they don't want to provide you the care, maybe they just don't have the tools always to do it, depending on where they're practicing and how many patients they have. So for rare diseases, I absolutely think it is, but most nephrologists are extremely good physicians overall, and so they should be able to help you whatever the cause.
Okay. Got one more question queued up. If you got any in the audience, have maybe time for one more to send in to the team, we'll get it over. But the next to last question, what is a concerning UACR number? And for those of you who don't even know what that UACR is, please look into that, because it's a very important part of your care and identification. But what is a concerning UACR number?
Right. So maybe I'll start off with what is the UACR then. So urine albumin to creatinine ratio. I briefly mentioned earlier that albumin, which is a common protein, should not be there in the urine. But sometimes the filters of the kidney get damaged and you have albumin that we can measure in the urine. We classify albuminuria being less than 30 to 300 or more than 300 milligrams. And we know that it's a spectrum, meaning the higher the urine albumin, the higher the risk of both progressive kidney disease and cardiovascular complications. And for most diseases, anything above 250 or 300 is considered significant enough that we want to add therapies or even immunosuppress patients to bring the level of albuminuria down. Most clinical trials, for instance, say we will enroll people who have at least 200 or 250 milligrams of albuminuria. And the reason for that is once we get into the lower values, there's some fluctuation depending on how much fluid perhaps the person has had that day, what time of day was collected, etc. So there's a little bit of variance. But once it gets to above 300, I do think that that is cause for concern, and people should be on goal-directed therapy, whether it's, medications that can reduce the blood pressure and protein, or specifically drugs targeted at reducing the protein, depending on the cause.
Okay, great. And for those of you who are not familiar with our Know Your Kidneys webpage, that's a great place where you can go and you can plug your numbers in. It'll give you personalized talk to your doctor guide to have that conversation, going way back in the conversation on how to kind of advocate for oneself as well. I actually don't think any more questions have come in, Pranav. So maybe with maybe the minute we have left, what are some key takeaways that you want people to know?
Well, I think perhaps the biggest takeaway that I'd like people to know is that kidney disease is far too common. It has a shared risk profile with diabetes, high blood pressure, cardiovascular disease, and it's silent. So when you have 35 million Americans with kidney disease, and about 70 to 90% of them, depending on what stage they are, don't even know that they have kidney disease, that's a problem, because you can't get treated and you can't receive care if you don't know you have a condition. So especially if you have a family history, I would say get screened, ask about screening for kidney disease. And once you have a diagnosis of kidney disease, it's really important to keep those appointments, try and modify those risk factors, because we now have enough of tools to prevent progression of kidney disease, unlike the last 20, 30, 40 years. The last 10 years have been really exciting for us in nephrology, especially for the most common cause of kidney disease, which is diabetic kidney disease. And so if you have diabetes, if you have kidney disease, we can slow progression, sometimes even stall it. The earlier we detect it, the better chance at doing that. So early detection, awareness, and advocacy are really important for preventing kidney disease progression overall.
Fantastic. Well, thank you all so much for joining today, for your really, really great questions. We hope you found this workshop helpful and insightful. Pranav, a big thanks to you for sharing your knowledge, and to all of you in the chat too. It really made this a fantastic experience. If we didn't get to your question, don't worry. You can visit the info desk and the AKF webpage for additional resources. Before we wrap up, you will see a link for a quick survey in the chat on the right. Please take a minute to fill that out. Tell us how we did. We do use that feedback every year to make future sessions better. I want to thank you again for being here. We hope to see you in our next live Q&A workshops. We have one with renal dietitians and one with the team that manages our charitable assistance grant. So, if you're looking for questions about, how to eat better and manage your kidney disease that way, or learn about what programs AKF has to help you if you're on dialysis or if you've received a transplant, we'll get those started in about 15 minutes. Until then, have a great day.
Thank you.
Thank you.